Here I'm speaking as PI of Canavan, which is a systemic AAV9-based gene therapy for Canavan disease. To introduce Canavan disease in this group is probably a little like carrying owls to Athens, but nevertheless a single gene disorder that affects aspartoacylase. This is the enzyme necessary to degrade N-acetyl aspartate that builds up in the brain and can be detected on MR spectroscopy in CSF as well as in urine. The resulting phenotype in children is quite devastating and starts in early infancy with children having macrocephaly, severe hypotonia, head lag, seizures in subsequent months, and really making no developmental gains. So it's one of those devastating disorders similar to infantile Krabbe that you heard earlier about. So the work that we undertook here in clinical trial is based on really decades of advances that have occurred in Guangping Gao's lab, as he not only discovered the gene, but also advanced AAV9-based gene therapy for this condition, recognizing that here a loss of function disorder could benefit from gene addition, and knowing well that here there was a clear biomarker, not only in N-acetyl aspartate, but also in the severe brain demyelination that's visible in MRI in the first months of life. The brain MRIs show very early on severe white matter involvement, not only supratentorially in swelling of the white matter, but also in the brainstem and cerebellar peduncles, where early myelination is so important. So far in this trial, we've enrolled 6 infants to date. Our inclusion criteria were that you had to have mutations in ASPA, show biochemical evidence of N-acetyl aspartate elevations, and be under 30 months of age with symptoms of classic Canavan disease. We excluded all patients that were more advanced in the sense of having recalcitrant seizures or opistotonic posturing. So we have now, we're about 17 months out, I think, from the first child treated. 5 of these children were treated at Mass General, 1 at Cornell, and the administration being intravenous AAV9 ASPA at a dose of about 10 to the 14th vector genomes per kilo. Our first concern was, of course, safety, and the kinds of adverse events you see with this kind of intravenous administration is similar to what you would expect after systemic AAV9 as seen in SMA. You can see thrombotic microangiopathy as well as liver enzyme elevations. We treat with prednisolone concomitantly to our IV AAV9 in order to blunt those kinds of immune responses. And in the 6 children to date, we've been able to successfully avert any immune responses that might have led to hospitalizations due to AAV9 administration. That being said, we have seen that platelets drop after AAV9 administration. We see that weeks after administration, you can see liver enzyme elevations. All of this we manage with further increases in steroids. But most excitingly, we've seen a drop in NAA in urine as well as CSF and MR spectroscopy in all patients to date. So the really high N-acetyl aspartate levels that usually occur drop within just weeks in these patients, and the treatment has been well tolerated. Most of these children have such severe head lag that I've been very excited to see some of these children starting to make more eye contact and start to move and turn their head, but it's very early days. And we've had one child who was treated at 21 months who's been able not only to sit, but start to stand and take first steps. So that's been one of these moments where it feels like a privilege to be a child neurologist here. So I think that was going to be my quick summary. And David, sorry that I didn't have slides here. The things I could have shown you on slides were that you see these dramatic, rapid, and sustained drops in N-acetyl aspartate, and also that the brainstem and cerebellar peduncles start to myelinate after administration of this AAV9 ASPA. So I think both of these good evidence that we have proof of concept that something is happening here biologically.